Late bloomers. I figure I'll start blooming anytime. Steve, that reminded me. There's this This American Life podcast, and it was mostly focusing on, or one of the major stories was a doctor in Southern Oregon. I can't remember exactly what his specialty was, but similar to he was an immigrant, was on a work visa, and he was desperate to go over. I mean, it was, I can't remember, and like Dr. Souza, you'd probably know what field I'm butchering off the top of my head, but whatever, you know, it's directly applicable to pandemic disease outbreak and actual like hands-on action. And so he was desperately trying to be able to go to New York to volunteer to work, to help out. He had friends there, and they just wouldn't let him because of the work visa. And, you know, his friends are calling him saying like, hey, we're dying over here. You got to get over here. And he had, you know, his choice was, you either go help people in the part of the country that needs it the most, where you're doing okay right now in Southern Oregon, or you get kicked out of the country. Or if you do that, you get kicked out of the country. So, or you get to stay in the country. It's just such strange bureaucratic calculus he had to make.
Yeah, that's unfortunate. I had a couple of colleagues here that wanted to go to New York because our volumes went down. They weren't busy, and the bureaucracy was it basically they ended up deciding it was just too hard. That's such a shame.
Yep.
Yeah,
I've got a friend that just scheduled a colonoscopy so that he could go to Alaska fishing, because the only way you get a test back in New York was to have the surgery coming up. So he's like, it's so insane. It's just like,
oh.
And the best part is, you know, Alaska's got it set up so if you show up and you didn't have a test, they'll just test you at the baggage carousel. You know, they'll just test you.
Will they really?
Yeah. Now the trouble is, if you're trying to, you know,
pay?
like, you have to say, I'm going to go here and I'm going to stay here and I'm not going to go to the grocery store. And then, you know, when they get the result back, they know where to find you and let you know. And it's all on your honor. You know, there's no Gestapo waiting at the airport, you know.
Right.
Like for me, I'm going to sign up, you know, I'm going to do my test here. I'm going to go, and then I'm going to do whatever they tell me at the airport. And they're going to give me a voucher, because if you're there for more than a week, you got to get a second test. But they're handing me a voucher to get it, and I just go get it, and you know, then I got to hope that I get the result back before my next scheduled flight to go fly to another village. And but it's all based on your honor. You know, it's not.
Yeah.
It's not like you get thrown in jail or, you know, incarcerated, whatever. It's a start, right? It's not perfect, but it's a start, I guess.
Yep. Well, we're starting to get folks in. We still we had about more than double this registered. So everybody's joined in. Thanks for coming. We'll probably give it just a couple more minutes and let some more folks who had registered try to show up here, and then get going.
Aaron, am I a participant or am I a co-host?
Let me see.
I'm not seeing the same screen I saw the other day. That's why I asked. Which I don't care. I just assume you have all the buttons.
You're co-host.
Really? Okay.
Yep. Yeah, for some reason you're signed in as me. I don't know how that works, but.
Oh my goodness. Well, I'm glad you're in charge of technology. I can blame you. That's right. I'm Aaron Lieberman. What the heck?
How's it feel? Not all it's cracked up to you.
I hate to.
Don't buy the hype.
Yeah. Well, the last time Jess was me, and now I'm you. And
yeah.
Jeannie, how are you this morning?
I'm doing well. It's a beautiful day here in Salmon.
Finally.
Yeah.
My poor guests have been out there getting snowed on for 4 days on the Middle Fork. I'm like, oh boy, they got sunrise this morning. Thank goodness.
Yeah, Gilmore Pass, I heard yesterday morning, was just a winter wonderland. Not real great. So I was imagining that the Middle Fork must be the same way.
Yeah, well, all's well that ends well, and they'll have sunshine the last 2 days, so that's good.
Yay. And I'm going fishing over on the Big Hole this weekend. And all the bugs that wanted to come off the last few days are going to be coming off, and the trout are going to go crazy. That's
I hope they do for you. We're probably good, Aaron, I'll bet. As good as it's going to get.
I think so. All right. Well, we'll probably have more folks coming in. But to start, welcome, everybody. I'm Aaron Lieberman, Executive Director of IOGA. A couple housekeeping things before I pass it over. If you are new to Zoom, this in the webinar format, you are by default muted. We may well have an opportunity for sort of some Q&A at different points throughout or at the end. In the meantime, if you do have a question that you want to pose to any of the panelists or just in general, there's a Q&A button which brings up a little field there. You can put your question in there. I will do my best to answer it if I know it. The odds are I don't, in which case we'll see if we have time to field it out to people who might. This webinar is being recorded. We will try to get it up with a link to for all the folks who are out on the river or in the woods and couldn't make it today, so that they can take advantage of it as well. Let's see here. The panelists themselves we have today, I think we may have Amy on the line. Actually, Steve, I was just trying to figure out if that phone number that called in was Amy, so I could give her permission.
It is. I got an email from her. She's on.
Okay. Well, Amy, I will try to give you permission to talk here in just a moment. We're otherwise joined here by Dr. Souza, Chief Medical Officer at St. Luke's and co-chair of Idaho's Task Force on Testing. By Tina Upson, the Executive Director of Crush the Curve, by Jeannie Gentry, CEO of Steele Memorial Medical Center. We have longtime outfitter and leader of the O19, which is the task force or committee assembled by IOGA to assist with deal and expand efforts related to COVID and operations. And myself and Amy. And Amy, while I'm thinking of it, let me see if I can add you. Well, I can't. Amy runs a clinic out in Stanley. So with that, Steve, I believe I was going to pass it on to you. I think we're going to, just to give you an idea of what we're going for here, we're going to do a quick review of sort of like 5 key takeaways from the discussion last week and part 1 of this, and then go into, and I'll let Steve introduce exactly what that focus is, what we'd like to talk about, or what we encourage the panelists to discuss in this session. So Steve, unless I missed anything, I'll go ahead and pass it on to you.
All right. It sounds like I'm identified as Aaron Lieberman. So Aaron's just, his overreach is incredible, but I'm Steve Zettel. First thing I'd like to say is if you're joining us and you didn't watch part 1, if you're considering testing as a business owner or a healthcare provider in a small town in Idaho, you should spend the hour and 45 minutes that part 1 was. I didn't really have the benefit of understanding what the information was because we were kind of running the show, but I went back and watched it and took notes and whatnot, and it was incredible how unentertaining it was, but how totally informing it was. We had some great panelists, experts in the field, and I highly recommend part 1. Some of the things you might have missed on part 1 is that this conversation is directed towards testing and commerce. We understand that medical testing is really important. We're trying to avoid that part of the conversation here. This is testing resources and how they can be used and affect commerce and opening the country. Warranted or not, there is a desire to be tested around rural Idaho. May not be scientifically correct, but sometimes consumer confidence and small town confidence isn't always rational, but it is what it is. And so we need to realize that. We also talked about a couple of the other states and some of the things they were doing. There's some good examples out there in Alaska and Utah of how they're utilizing testing in a positive way to open up commerce. We are talking mainly diagnostic testing. I think we narrowed the field down to diagnostic testing. So basically, we're trying to see if you are sick and not antibody testing, which means you were infected somewhere in the past and you're showing antibodies to it. We're focusing on the diagnostic testing end of things. We also talked about the future of testing, and it just seems like the Abbott ID type quick test is really what's going to benefit the country the most in the future. But even now, in most cases, most people can wait 12 to 72 hours for a result without, too much negativity going on. But when we're talking about tourist travel, the quick test is probably, our holy grail that we're looking for. And last but not least, on that topic, Crush the Curve and Tina, who you'll hear from, is actually playing a huge role in testing in Idaho right now on the commerce end of things. And I don't see where that would be any different when it comes to small town testing. I think that they're hitting it out of the park, and there's no reason to reinvent the wheel. We'll just utilize their services and the state as much as possible. And I'm just going to read this verbatim. I just think that a combination of the state resources and an open-minded healthcare provider with the help of Crush the Curve seems to be the answer to rural testing deficiencies and desires. So, and with that, before we get going, I'm going to bore you with a little economic class. Okay, I'm a numbers guy, and we've talked about cost of testing, and we talked about what the resource availability may be and whatnot. And this is all under the assumption that resources are available. Okay, if resources aren't available, then it doesn't matter how much you pay for something, you're not going to get it at the volume you want. But if testing resources continue to decline, then these facts will ring true if in fact Idaho has issues as the summer progresses or into the fall or even to next winter. And so I'm going to start with saying that the outfitting industry is a $1.2 billion industry in Idaho. And the fun fact there is that 80% of that revenue affects towns in Idaho less than 500 people. So we are the financial impact on small communities. So we're a $1.2 billion industry, and 80% of that is affecting towns less than 500 people in Idaho. So, and we've come to the realization that small towns in Idaho, especially around places like the wilderness and national forests and whatnot, are truly outfitters. They're not places we work. They're just like us in a bigger way. They are outfitters, and everything they do is they think and act in just the way an outfitter would, for the most part. So some quick examples. Middle Fork float trips, I'm well aware of that because that's what I do. Maine salmon wilderness trips, pretty similar to that. Those two together will equate to about 10,000 outfitted users a year. Okay, and let's throw a ticket on that of $2,000. All right, so those 10,000, that's $20 million of direct revenue to the state of Idaho in small towns. An economist will tell you that's going to bounce around Idaho probably 7 times or more before it leaves the state. So that's meaning that I get my money, then I pay my guides, and I go out and buy groceries, and I buy a new truck, and they buy groceries and new truck, and then the car dealer, he buys groceries and gas. And so every time that happens, what we need to wrap our head around is that every time that happens, there's a good chance that the state collects 6% sales tax. Every time. So when we take $20 million, multiply it by 6 times, And let's say a fraction of that is sales taxable, because some things aren't. But if the reality, it should have been 8 times. So let's give it a 5. You know, all of a sudden, we're talking $100 million of revenue that's getting 6% sales tax every time. Okay. And let's see, what would it cost, just hypothetically, to test, you know, 10,000 users at $100 a test, right? It's $1 million. But we're talking a sales tax revenue of $6 million. So, and all the other benefits of putting people to work, So the notion that there's not enough money for testing is kind of ludicrous, because, like, you know, what would it be like if those folks didn't come? Now all of a sudden there's $6 million of direct sales tax to the state of Idaho, and that's a low number, not coming for the sake of $1 million it would cost to test them at $100 a pop, and probably it would be less than that, you know. And we're not advocating the notion that we should go out and test all these folks, but in isolated areas, that same ratio just plays out. Now, when we get into the fall, and we're talking, let's take elk hunters. There's 100,000 elk hunters in the state of Idaho, and 2% of those, 2% of the elk hunters are outfitted elk hunters. So there's 100,000 plus elk hunters out in the field. 2,000 of those will be guided. And let's give those guys a value of 5,000 apiece, right? And so, you know, there's 10 million bucks right there. Do all the math all over the place, you know, that sales tax revenue, you know, we're up over $3 million. And if we had to test every one of them coming out of our pocket, it's 200 grand. All right. So the direct sales tax benefits to the state of Idaho is $3 million. And it would cost us $200,000 to test every one of them when they came across the border, if we had the resources to do it. Okay. So all that's to say that money shouldn't be the issue here. You know, there's enough money on the table. Plus, if you took the average elk hunter, the average fisherman, the average, you know, family vacationer, even if you told them they had to foot the bill for it or part of the bill, they would do it. You know, so let's keep that in mind as we move forward, that don't let economics slow us down. And Tina knows that better than anybody. She, you know, that's the game they play. So with that said, I'm going to turn it back over to Aaron, and he's going to, I think, bring up on the screen what our goals are today and run us through them.
Yeah, absolutely. And while I do that, I wondered if maybe Dr. Souza, starting with you, and then on my screen, it's sequential with Dr. Souza, Tina, Jeannie, and I think Amy, if that is your phone number, I allowed you to speak. While I'm bringing that up on the screen, if you wouldn't mind just starting us off, Dr. Souza, introduce yourself if you want to add anything to it, and then any key points, you know, taken away from last time, if you had a chance to look at those notes, or from Steve, and or what you'd like to share with us today, and then we'll just sort of go round robin real quickly, a couple minutes each, and then move on.
Cool. Hi, my name's Jim. I'm a pulmonary and critical care doctor by training. Grew up in Montana. I've been practicing in Boise, Idaho since the late 1990s, and at St. Luke's for 21 years. I've been in, I still practice clinically. I'm a pulmonary and critical care doctor, as I said. So COVID-19 happens to be the disease that's in my wheelhouse when it ends up at the severe end of the spectrum in an intensive care unit with folks with respiratory failure. I've been in leadership at St. Luke's since 2012, and then I've been our system's chief medical officer, which, you know, for the non-clinicians sort of means overseeing the doctors in the health system for the past 3 years. I just want to be helpful to this group. I've been talking with Steve since I got pulled into the state testing task force. I think in closing the gap on the how, like the state of Idaho needs to come around that in an organized way, big time. We were so behind the 8 ball on that. I know that Crush the Curve Idaho is going to be an important part of that solution. Healthcare systems can also be part of that solution, but we do all need to come together in a coalition of the willing and come up with a plan. So anyway, I'll be as helpful as I can, Aaron, in all things delivery system, biology, testing details. So I'll shut up. Talk too much already.
No, thank you, Dr. Souza. That was great. Tina, would you mind following up? And then, for everybody who's on last week, Tina joined us last week. Maybe any takeaways you had from last week, or where you think the conversation might be most constructive today. And I like where you led there, Dr. Souza, with coming together and opportunities and seeing what we can do in a coalition. Anyway, with that, Tina, if you wouldn't mind just giving a brief introduction and speaking to anything you'd like to talk about today.
Sure. So Tina Upson, Executive Director at Crush the Curve, Idaho. We're a 501c3 nonprofit that has been around for all of 9 weeks, just trying to figure out how we could best help show up to support any and everything related to COVID and safely reopening businesses. And a majority of our efforts have been working alongside of employers, trying to navigate all of this. And, I think that Dr. Souza said it correctly, and I felt like where we left it last week was a lot of questions around the how, and I felt like the question from the audience was, what are the nuts and bolts? Do I need to be testing? If I do, how often? And then we heard from local clinics, they simply could not execute on that kind of testing, and nor maybe should they with the limited supplies they have, and the fact that they should be able to keep, I think Dr. Ball asked them to, hold some supply back, right, for symptomatic or higher priority groups. So I think, it's probably, where I would hope the conversation would go next is just to understand from a state perspective, if we don't have the capacity to take care of all of priority group 1, what kind of pressure, if any, should be felt by this priority group to try to make sure that their employees are tested and that sort of thing. I think that would be a healthy thing for us to help understand. I think we're really blessed to have Dr. Souza here with us, because he sits right at that table and he knows how close or far anyone is away from answering that question, for sure. You're muted, Aaron.
I was hoping that everybody would just intuit what I was saying. You missed it. It was really insightful. Jeannie, if you wouldn't mind just following up there. And Jeannie was also, you were with us last week, your sort of key takeaways, or, again, where you think this conversation can be most constructive today.
Yeah, I'm Jeannie Gentry. I'm the CEO at the hospital here in Salmon. Salmon, like every summer, it looks like everybody in the world is going on a raft right now. And we've started to have people come in and want to be tested, and especially people going to Alaska. So Steve, you're not alone. So I learned a lot last week. Hopefully I shared a bit about the challenges that we have on having enough testing capability to serve our community's needs commercially rather than medically. We're able to test all the people that present with symptoms. We're able to test all of our pre-op patients, but right now we're concerned about if we start testing other people for other reasons, getting enough test kits. So Tina and I are going to talk next week and see what she can do to help us. And I think that we can serve that community. We just need to be assured that we can get the supplies of test kits. So that's why I'm here today, and to see the guide community and the clients that you serve. They're very important to the salmon community and the salmon economy, and we want to take care of them. So that's why I'm here.
Hey, thank you, Jeannie. And Amy, are you still with us on the phone there?
Yes, I'm here.
All right. So we can't see Amy, but she is here. Amy, would you mind just introducing yourself again and sort of same prompts, and then we'll dive in?
Sure. I'm Amy Klingler. I'm a PA, and I run the Stanley Clinic, so the Salmon River Clinic in Stanley. We like Jeannie, are sort of on the front lines and experience an explosion of tourists this time of year, especially related to the guide community. You know, early on in the season, we've had a few of these calls, and we started seeing an influx of guides and outfitters starting to think about how they were going to begin their season and then continue with testing. Now we're also starting to see a surge of tourists, some who are traveling. We're seeing symptomatic people, asymptomatic people, but everyone is concerned about COVID. So, you know, my thoughts have evolved a little bit even over the last week on what the availability of testing, you know, our priority 4 and 5 groups are, as opposed to our priority 1, 2, and 3 groups. So, you know, my big concern this week that I'm hoping to sort of talk about is what the need is really in the guide community for testing of asymptomatic versus symptomatic people, because what I'm seeing in our community right now is a real need to focus on people with symptoms, as opposed to, you know, that kind of testing when people come off the river without symptoms before going on their next trip. So I'd like to touch base on that sort of logistical thing if there's some time today. But you know, what we're seeing is a whole lot of concern about COVID, a whole lot of symptoms that can fall in the range of COVID or a wide variety of other viral illnesses, and limited resources, like everyone's talking about. So.
Yeah, and you know, so thank you, Amy. And that's one of the, and I think with everybody so far, and understandably, one of the key areas that I think everybody spoke to is the tension between availability and applicability. So, and Tina, you spoke to like, what is the actual, I think everybody did actually, like, what is the actual need to test guides, say, as a subset, or as like even just in the abstract, as a type of group in these communities? What is the ability to do so without sacrificing or impinging on the availability of tests for people who are symptomatic or are in, you know, more vulnerable classes? And I guess, you know, we do have, I hope everybody can see the sort of outline, and really there are just some thoughts down there. But I'd like to, since everybody seemed to zero in there, maybe first go to back to Dr. Souza and then to Tina, either to respond to or build on anything one of the other panelists mentioned, and or to speak to your take on, maybe specifically to you, Dr. Souza, availability versus use in different classes or categories or priority categories.
Yeah, thanks, Aaron. So I don't have you know, prepared comments or anything, so I'm just going to be speaking off the cuff. Yeah, that gap between capacity and demand, you know, I'm going to admit that what the testing task force came out with, we got to be honest, it was a swag, and we got to get a lot better than a swag here in the next round. So just to put a place marker out there in coming attractions, just 2 days ago, Dr. Hahn, the state epidemiologist, did reach back out to me wanting to reconvene the testing task force. And I got permission from my boss to give some more of my time to that. And I will do that, but I've been pretty clear that we need a differentiated output for the input this time. So our assessment of actual supply and actual demand has to be a lot more accurate. And then we've also got to add in these new indications around asymptomatic. We probably need to reevaluate our priorities. And then really importantly, we need to make this pivot to the how. And we gotta take this, what I call the coalition of the willing, and just decide. I mean, I'm the physician leader of the largest health system in Idaho. I know we have some excess capacity with current disease activity in testing of symptomatics and even the asymptomatic pre-procedural testing we're doing. I know that we have helped some vulnerable population partners like a long-term care facility when they're faced with an outbreak to bring mass testing. I know Crush the Curve Idaho has been asked to do the same. We just got to decide who's in which lanes and who's doing what. I do want to make a point about prevention and protection in addition to testing. I know that, well, actually, let me come back to testing for a second. So the SWAG number, for those who didn't see it, and I think, I don't know, Steve, if this got discussed last time, but the testing task force SWAG was current state capacity circa first week of May 2020 was 23,000 tests per week. And just to test priority 1 and 2 patients, the SWAG, again, was 43,000 tests per week. Now, I'm aware, I don't think our capacity has increased. I know Crush the Curve's capacity has increased. I think our current capacity in that SWAG might be closer to 36,000 or even 40,000 tests per week capacity in the state. I do think that the priority 1 and 2 SWAG was overstated. So anyway, we have to get a lot more discreet on that. But I'm going to come back briefly to prevention and protection. I want this group to know that 2 important pieces of data came out scientifically in the past. Well, one's sort of pseudoscience, but it was a natural experiment that occurred in the last 10 days. And this has to do with masking and good prevention practices. As a physician who wears a mask all the time at work, it's like I'm kind of scratching my head how that has become politicized, and it's sort of unfortunate. So I'm just going to give everybody a dose of science. World Health Organization commissioned our best evidence to date with a meta-analysis. What a meta-analysis is it takes a bunch of small studies and mushes them all together and tries to draw a larger and more meaningful conclusion than any of those tiny studies could. They mushed together more than 40 studies. And the output of that is that wearing a mask, even just a simple cloth mask, appears to reduce transmission from infected people to non-infected people by 83%. That's true in healthcare situations and in the community. It's more in healthcare situations. It's probably a higher number because the quality of our masks are better. The second kind of natural experiment that occurred, I don't know if everybody on the call heard about this, but about a month ago, 2 hairdressers in Missouri got symptoms, went and got tested, both confirmed positive, made the completely irresponsible decision following their governor's decision to allow reopening to go ahead and open their shop, to not disclose that to any of the people that came into their shop. And they exposed more than 150 people until they were outed and they were shut down. What that created, though, was this really cool natural experiment. And you know what the outcome was? 150 exposures, 0 conversions. Now, why did that happen? The only explanation we have is the practices that those 2 women employed. They wore a mask all day long. They cleaned surfaces like slavishly. They changed their physical locations in their shop in order to protect, one client from another client. So I just don't want us to forget those, since I'm afraid we're going to continue to be in a scarcity situation in testing at a high level in our state for a while, even though I'm optimistic things are improving. Please, I hope everybody, kind of tries to model that good behavior and turns this conversation from a red-blue politics kind of conversation into what I think as a physician it should be. It's like a science conversation. With a respiratory pathogen that's spread by droplets, it's like, duh, masks work. Anyway, sorry.
No, you're fine. And I mean, turns out science, right? So I appreciate the sort of prevention message, right? And I think that outfitters have really taken quite a bit of time to put together preventative measures, mitigating measures within their own operations. And I think you mentioned also the pivot. And I want to go back before the pivot and just before the pivot, because I do want to pivot there. But before the pivot, Tina, you brought up when you first spoke, the question of, should we be testing guides and or use guides as a representation of similar such service providers? Should we be testing these consumer facing populations, and if so, how often? Because that the sort of the broad answer to that question, it seems to me, speaks to informs how we answer the how question, right? So Tina, would you mind elaborating on that a little bit, and then maybe we'll go from there briefly just to the if and how often, and then to the pivot.
Yeah, I think one of the unintended consequences of rolling out 5 priority groups at one time, right? Although it was very clear that that's what was asked to do of the task force. So it's no disrespect, was the what, right? And it wasn't said to, hey, do this based on current capacity or, that sort of thing. By rolling out 5 priority groups, it created what we saw, because again, remember, it's mainly employers reaching out to us, a lot of different emotional reactions within these priority groups, such as my employees now don't feel safe because they were told they're in a priority group and I can't find testing where I'm at. And that is one of those things that's happened. Or how often should I be testing, right? And again, I think what Dr. Souza is saying with the swag is that number isn't really based on someone saying, okay, we think that 40% will actually adhere to repeat testing, and our recommendation is for guides that they would test every 30 days, right? I mean, no one's really kind of said the number. Even I think we're starting to see some of those call outs for a range for that priority group 1, right? The nursing homes, assisted living. We're just starting to see what they actually meant for ranges. So what's happened is the unintended consequence, right, is it's not only caused a question mark for the employer from a cost perspective and all the things we talked about. There's not capacity even if there was no cost issue. And then it's created an impossible. Now they have employees that don't feel valued. My employer doesn't care about me. In some cases, they're not even going to work. And so those are some of the things that we're seeing from this. And those are the things where my hope is, and I'm grateful to hear the group may reconvene. My hope would be that we could set a priority group based off of known capacity and make sure that it's not just all of it falling on the employer's shoulder to kind of figure it out. I know we received a call from multiple priority group 1. These are the groups where if that disease gets in their organization, this illness, virus gets in there, people die. And our phones ring off the hook yesterday after some call that happened where the state kind of went through what's expected. And what's expected is for them to figure it out. There are no major healthcare providers that are doing asymptomatic repeat testing for you. Figure out, they gave them labs that they could call directly to try to get their own kits and figure this out. That's what they gave them. So they're calling us. We'll do our best, but it's very disjointed, even at the highest priority group where people will die. So when I say should people be tested, I don't ever want to be on the record saying people shouldn't be tested that are in a priority group from our governor. I find that disrespectful, but it's impossible to truly test and at what cost? Who are we not testing if we do show up and test very proactive, call it priority groups 4 and 5 that we're seeing? We're finding that a lot of capacity is being chewed up to test football teams. We have major healthcare systems choosing to test football teams right now. I can't get them to help us test the assisted living facility. These are things that we need to expose, not because people need to be called out in a rude way, but because people die in those higher groups when that disease gets in there and that illness gets in there. And I call it the wrong thing because I'm not a medical person, so I apologize, Dr. Souza, but those are the concerns on our heart. Those are the concerns that we're hearing from an employer that the priority groups and calling those out have done, is left them vulnerable to have zero resources to deliver to their teams. And now their employees feel like they're not cared about. And to the question of should we test them, if I only had enough tests to test assisted living facility or outfitters, I mean, I think that everyone would answer that the same, including the outfitters, but we just don't have anybody giving them a pass to do so publicly enough where their employees don't feel like it's not, the water doesn't get to the end of the row for employees to know, oh, okay, that's why I'm not being tested. It's not because I'm a priority according to the governor, but my boss doesn't think so. It's because there's no tools available and I'm taking it from the elderly or those with comorbidities that wouldn't be able to survive the illness, and I'm okay with that. And my hope is we can get there on that communication sooner than later, because it's really causing a lot of issues that we're seeing.
Yeah, thank you, Tina. And from that, because I really do want to get to the how, and to what actionable steps we can identify when we have such, engaged and smart people as you available for a conversation to get to what we can actually do next, not just talk. And I know you're all really interested in that. That's why we asked you to be on this. Why I appreciate you. I guess real quickly, and really this one to either and Dr. Souza, Jeannie, Amy, if any of you would like to speak to like the should question, and like just in very briefly, like should in a procedural sense, like these guide employees and many others in rural Idaho and similar sectors the answer is yes, that they are supposed to be tested, right? They should be tested. But the question, I guess, so real briefly, maybe from your different perspectives, in just 20 seconds, you can say like, should we be doing that? And if you have a sense of how often, without getting necessarily into the conflict between the different priority categories or groups yet. Does that make sense? In whatever order.
I think you're asking, Aaron, just assume that supply is and capacity is not an issue. If we were no longer in scarcityville, should we be applying testing in order to facilitate safe business and safe healthcare?
Largely, yeah. If in general terms we had sufficient capacity to provide or to to hold and reserve tests for those more vulnerable classes,
yeah,
should we then? And as laid out in the guidelines.
Yes,
Okay.
I just say yes. If we weren't in a scarcity situation, it would truly enhance the opportunity for both safe businesses and safe healthcare.
Okay.
Yep.
Yep. And Jeannie, Amy, I'm guessing you're also pro-testing both for legal reasons as well as for medical and public health reasons. But anything you'd like to add, sort of that general question before moving to the more of the nuts and bolts of it?
Yeah, when you say should, really, I agree with Dr. Souza. Should we test everyone? Sure. The fact is that we don't have unlimited capacity right now. And I mean, just this week, I got royally cussed out by a guy that wanted to be tested because he was going to Alaska. And right now, I cannot afford to test a low priority, which to me, he's a low priority compared to patients showing up that are symptomatic and pre-op patients, because I barely have enough to do all of those. So if I had unlimited capacity, he wouldn't be low priority. And honestly, testing guides and clients that are going out on the river is not the highest priority in our community. But that question is spreading. It's not just a guide question anymore. It's, all my Forest Service people now are thinking we should be tested too. If the guides are getting tested and the clients are getting tested, all of us should get tested. And pretty soon the school districts going to want to go back to school. And are we capable of that? I don't think that we are here in a community like Salmon. And even if we got a lot of test kits, we can only staff and have the machinery to do just so many in a reasonable turnaround time. So there have to be priorities right now. And I don't even understand what these priorities are exactly, but I know that a bunch of healthy athletes that are going down the middle fork probably aren't in the top priority. Just saying.
Yeah.
So
Yeah. Well,
that's what I'm struggling with.
Yep. Yep. Amy, briefly, is there anything you'd like to add? You'd like to add on this front before I jump back in?
No, I agree completely with what everyone's saying, and that of course, without the scarcity, we should be testing and we should have a framework for how to do that. The problem is that we are in a scarcity, and last week on the call, I said we had done some guide testing, and that, I hadn't seen communication saying that absolutely we shouldn't be doing it. Later that night, I saw communication saying we absolutely shouldn't be doing it. So since our last call, I've really reversed my position and kind of am in line with this group. So I want to make it clear that, our first priority really is symptomatic people in these higher risk groups. And I anticipate needing as many tests as possible in the coming months for exactly that. And, Steve made great arguments in the beginning opening remarks about the economy and the contributions that outfitters and guides make to this. And I think it's wonderful. And the problem is that cost is not the issue, and money is not the issue. It's availability and the scarcity. So absolutely, we all believe that it's important to test the guides. It's just the availability.
Yep. Yeah, and that's it. And that provides a great segue, because and I know in asking the should we test question, I anticipate the answer is going to be yes in general terms, but
yeah. And Erin, can I make one more point?
Sure.
Here we are in a hospital and a clinic, and I can't even test our own employees that just want to be tested because they're worried. I don't have enough tests to test our long-term care facility in town and their employees. And so, I don't want to be the one to tell the guides or the clients, no, we're not going to test you. But dang, but really, you're not in harm's way the way that my employees are, and I don't have enough to test them.
Yep, absolutely. And I think, Jeannie, Amy, and anybody in rural Idaho would attest that guides and outfitters, like, there's not a distinction between us and our communities. Like, we are, like, these communities are built out of us. We're part of it. It's a body politic. It's one organism, right? And so when I asked the should question, it's really, really, you all did admirably to help frame up, like, yeah, of course we should. We just need to we need to have more capacity. And so I think the practical, Dr. Souza, to get to your end, actually before that, Steve mentioned Stephen going into the economics of it. Another sort of the side point that you also referenced there is, like, I think we know that we are not the priority group, that we should not be tested before long-term care facilities, people in long-term care facilities, or those employees. I think we know that. I think we also, whether in the industry or in these communities, as you spoke to in your opening remarks, Jeannie, know the significance, the necessity of the economic contributions, or the economic or activity that outfitting, guiding brings into, and similar such industries bring into these communities. And in a conversation with you, Dr. Souza, we had a conversation a month ago where we talked a bit about how we can't necessarily see economic health and public health as these distinct things. And so I guess to go to the practical pivot, the question I'd love for again, you all who are smarter than I am, to maybe share your thoughts on, like, so how do we do it in stages? Right now, it's like, to what degree do we test anybody who is not priority 1 or 2 until we get to availability? How do we augment current availability and or throughput? And maybe more to the point for this call, and all of those things, more to the point for this call, what can we do what actionable things can we actually do today, tomorrow, next week to start building what you, I think, Dr. Souza referred to as like the coalition of the willing. And like, I guess I'll leave it there, and either Dr. Souza, Tina, whoever wants to jump in to speak to those things, if you could share some insider wisdom or ideas, it'd be great.
I'm just going to call a spade, that how testing across asymptomatics is being applied right now is, I'll even kind of just use maybe the more charged word. I think it's unjust. I mean, so just use the football example and the guide example. So we got football, certain football teams being tested on a regular basis that are that would be in the same priority level really as your guests. Where those folks are being tested in order to allow sporting events to occur. You guys are talking about testing people in order to safely allow, outdoor adventure trips to occur. They're both important in their own way. Yet one group is like finagling, a way to get it done, and another may or may not be. That's not just. It's sort of a clown car way of allocating these resources, and at the state level, we need to do better. And I'll be in communication with leaders at Crush the Curve, Idaho, with my crosstown neighbor, St. Alphonsus. We have got to come forward with a more logical way of allocating these things. What could be done right now? I don't know if Tina has, I know CTCI has been in conversations with the state about kind of helping respond to these hot spots. I'm going to be honest, I don't have the latest and greatest on like Abbott ID Now availability and how the state's getting more of those and distributing those. I'll have more information in a couple of weeks on that. But to the degree that we actually slow down transmission, and therefore don't need to do as much testing, that's actually stuff that everybody in every place that they work, breathe, play can do. And I'll just say, I'm going to use our downtown Boise bar scene. I don't know if you've all heard, it's blowing up. Our state numbers are being driven now by Ada County in a way that they hadn't before. Primary Health Medical Group is clocking 25 new positives plus per day. They're almost all coming from the downtown Boise bar scene. If we had only opened that in a more logical way and said, like Central District Health would have said, hey man, these are the criteria that you got to do to open this bar here safely. And we're going to come in and do some auditing. And if you can't comply with that, we have the right to fine you or shut you down. I know that sounds heavy-handed, but that nonsense wouldn't be happening today. And because that nonsense is happening, we're burning through more priority 1 tests on symptomatic people, and it guts the ability to apply a smart and just framework for the non-priority 1 tests across the state. So anyway, I know you guys you got to manage your customers and your clientele and their expectations, but I do kind of think you have them in a vulnerable moment. They want to take that trip. You're in the driver's seat to be able to say, well, you know what? The way we take that trip safely is we do these things. And I think our industry leaders, I thought this from the very beginning, our industry leaders can help change the conversation about prevention and protection that will cause us to be totally successful in beating this virus. I talked to you.
Yeah.
Sorry, Tina.
No, you're fine, and thank you. And I'd just say, I think part of the question, and Steve, I've talked about this, not least with others, but part of the question when we ask it from the industry's perspective is as much from the community perspective. So when we talk about consumer confidence and community confidence, it means that we are trying to get to a place where we have enough tests that, like Jeannie can test people in her long-term care facility. because that drives community confidence to be able to open up safely with measures to the public, which spreads that message in turn to the public that they are welcome and that there is a confident community that they can come to responsibly. And so I think, preventative measures that I think as an industry, we've really gotten ahead of things there. I'm really proud of the industry. I think as an industry, we've reached out early to our communities, to our community leaders, medical representatives. We've tried to make it about us, not about the industry, but about us. And so when I talk about what are the steps we can do next, I'm not speaking specifically to how do I get more tests for guides? That'd be great if we get there down the road. But what I'm asking, I think, and what I hope that we can maybe get insight from you on, and maybe even participate in something or support something, is how on a community level where we live and operate, can we meaningfully augment, expand, change the way that we the availability or throughput of testing, or the way that we do testing in order to provide that or to support the needs of the community, to bring back or increase confidence, and to be able to meet demand from consumers more effectively. And I just went on a little ramble of my own there, but if anybody, Tina, do you have any ideas and or Jeannie, Amy, do you have any ideas for how we, what can we do next on our community industry level? How can we support our communities to do this?
Sure. And I think we had a question from somebody that's an attendee also, kind of asking about my response to whether or not guides are a priority, in contrast to the fact that, yeah, we are coming through to do testing and it is available to employers that want to do this. What we're trying to solve for is the emotional gap that we're hearing where guides are telling their employers, hey, I should be tested, I'm not being tested, whatever. Here's the fact of the matter is all we're doing is showing up and checking a box because we can on a group of individuals that may or may not be sick at that 1 minute in time. So it's great, and I'm sure we'll catch a couple people that are positive, and that's great, and we'll stop that spread. But it's really, it's more to check that box of showing up for your employees that we're hearing these employers are stuck with. They've been called out publicly as a priority group, and they're not doing that. So we do have 4 rural stops that we intend to do. Employers can send their employees through, but again, that's just for that one moment of time when that thing gets put in their nose, whether or not they were shedding virus. It's not a regular enough, repeat enough testing to do anything that's going to move the needle, but it will satisfy on the emotional or that gap there, that pressure side. And if employers want to take advantage of that, they can. So I do want to call out, that doesn't mean I think that that's a more important, an asymptomatic group of guides is more important than an asymptomatic group that's exposed to the vulnerable and works in a nursing home. But it doesn't mean we can facilitate that. We feel for the employers that have shouldered the burden on being called out as a priority group with an impossible task ahead of being able to test at all. And what we have found with other employers, oftentimes it is just that getting that my employer showed up for me type of checkbox in place. If I were to answer your question, Aaron, in what could we do to show up for our communities, I think it goes right alongside with what Dr. Souza is talking about. But the step further that I think would be helpful is for us to get more transparent on what we do when we have symptoms ourselves, when we're not feeling well, and or when we're around somebody who has symptoms. What is that? And I say all the time that if I catch on fire, I know to stop, drop, and roll, but nobody can exactly tell me what I'm supposed to do if I wake up today with a low-grade fever. And I think that for your communities, what would be the most helpful is to not expose yourself to and take people on trips that have really clear communications on that you're not going to take a family on a trip if someone shows up and is exhibiting symptoms, to if you yourself have symptoms, to not go to work. Those are more the communications and things that anybody can do in Idaho to be of help, is assess and take a personal commitment to community help. And when I've been exposed to somebody with symptoms, whether or not we know it's COVID, we need to be extra vigilant, and a mask is a very easy way to do it. That being said, we have a lot of concern at Crush the Curve in the fact of we can't bank all of our plans on people complying. I now work around doctors. I know doctors that have had heart issues and they walk by with an energy drink. So they're not going to comply on all the things. We cannot assume that compliance will happen. So then we'll keep that message. It is a no-brainer. I can't believe people wouldn't wear a mask to keep elderly safe. We say that all the time. It's sad, but at the end of the day, what's the other side? Like, how are we making sure that we're showing up for the most vulnerable? And I think that's the task that this group can't necessarily solve. But man, if anybody in this group and their employees are not feeling well, they're not going to work. And that needs to be just step one. And that's a new normal. That's not, we've all worked with walking pneumonia and thought that that was like how we showed up for our company. That is not how we show up at all anymore. And that needs to be the go forward, is what I would say if I were to try to give action items out.
Hey, Aaron, if I can, I'd like to chime in.
I was gonna ask you because you're the story you told me today.
Actually, what I'd like to do is re-identify the uniqueness of our industry, and I totally agree with everybody saying. We're not the bar where the locals all come and break the rules. You know, that's not the issue with the Idaho industry. The issue with the Idaho outfitting and guide industry is simply this. We, essentially, spade to spade, we are the typhoid Mary of COVID-19 in rural Idaho. Like, if you want our revenue, you've got to take the risk. Now, we're doing lots of mitigation in between to prevent the risk, but the reality is we're like, my clients aren't my neighbors. They're coming from anywhere USA, anywhere of the world. We're very unique in that way. Nobody else is bringing busloads of potentially infected strangers from all over the place into little communities and going, have fun. I mean, in essence, that's what we're doing. That's what we're trying to manage. We're not managing a bunch of little renegades running around drinking in the bar and not social distancing and stuff. It's a different dynamic. I don't have the answers. I'm just saying, but I do have the question. Like how do we get outside that other box? Like, I get it. There's these 5 priorities. I get it. But when I look at outfitters and guides being priority 4, yeah, my guides maybe are priority 4, but my situation is a priority. Like right now, I'd say my situation is priority 1+. Not my specific employees, but my overall being. I am the guy who's causing problems potentially. I'm the guy that's saying, you need to address like what I'm doing. I think I'm doing a great job doing it, but if testing plays a key role in that, then it is a priority 1. If it doesn't, then I get it. But no other industry is doing what we're doing. And it's the same in any other state. It's not just Idaho. Anybody that's bringing people from the outside into little villages and those kind of things is definitely an issue that should be on the forefront, I think.
Hey, Aaron and Steve, I only have a few minutes and I'm going to have to drop off, but I want to give you something tangible to dock into. This conversation needs to continue because you're right. You are in a unique situation. So the commitment is, I'll follow up with you guys after this call, and the suggestion, and this is food for your thought, is would you be interested in participating in our work here at St. Luke's across our footprint, that you could bring the knowledge there back to this larger group to launch what we're calling an adaptive recovery collaborative. We can't tell anybody what to do, but in the absence of organized leadership in the state and recognizing that our health system in our part of the state, where we're the largest delivery system, we are going to be the bottom of the birdcage for a disaster if it happens. And we're like, nobody's stepping up to lead these different layers and platforms of industry, higher education, commerce, arenas, restaurants, bars, outfitters. We're stepping up and saying, well, we got to start convening people. Our first meeting of our Southwest Idaho Adaptive Recovery Collaborative Group, I'm chairing along with the Chief Operations Officer, Pam Lindemone, and a local business leader here in Boise who runs an arena in the Grove Hotel, John Cunningham. underneath the leadership group, we're going to have a testing group that's going to come forward with playbooks, a mitigation group, a supported isolation group. So think about this Southwest Idaho ARC creating playbooks that are significantly more granular than the recommendations you've seen from the state. They have to be. On the other hand, they're not so granular, they're going to put anybody in a box, because what you got to do, what I've learned in my conversations with Steve and to a lesser degree you, Aaron, is like, I don't have the first foggiest idea about what you guys see and experience in real time in your industry. And you actually have more insight into the answers than I will. But I have more insight into some of the science that might influence good practices around prevention, protection, testing, and mitigation. Our structure is to take the Southwest Idaho ARC that's creating the playbooks and then implement those at a community level. So one in Wood River, Magic Valley, Valley County and McCall, we're very worried about. We're going to launch those 3 first. I think Wood River would be a really good connection point for someone from this group to participate at the community collaborative level, talking about all things adaptive recovery and putting your perspective into the conversation to help us make better decisions, and taking from that conversations things back to your industry group. That'd be the thing I'd ask you to think about. And the commitment would be, I'll speak with my co-chair as the Wood River collaborative gets stood up and say, you know, I've got a connection with IOGA and we need someone from that group to participate.
That'd be great. Thank you. And, you know, we have members all over the state, as long as those places aren't more than 500 people, as you heard in the intro. So they're certainly representatives, you know, beyond myself, who could really participate from within their community, I think, in a meaningful way. So that would be really great. Thank you. And thank you for joining. If you do have to drop off here, which it sounds like you do, and we are over an hour. We didn't put a firm end time on this, which I know is not proper Zoom etiquette, but we're outfitters, and so we figured we'd take advantage of having people around as much as we could. Looks like, Tina, did we just lose you, or did you just go away on my screen? Looks like we also lost. And we have Jeannie left. Jeannie, you are our sole, unless we're counting Steve masquerading as Aaron, you are our sole remaining panelist. Do you have anything you'd like to?
Amy's still on. Amy's still
Oh,
there.
sorry. Yeah, I didn't show my panelists. I apologize, Amy. Amy, Jeannie, anything you'd like to bring up or speak to in terms of practical steps that how Outfitters say can support you, or, you know, the use of a Riggins or wherever else across the state, what we can do to help augment or to, you know, help alleviate some of the burden on testing capacity within our communities, or to increase it.
Yeah. Well, I completely agree with, you know, what Tina was saying. The education has been the biggest thing that I've been trying to do, and is telling people how to prevent the spread of COVID, how to identify symptoms. I refer people to symptom checkers. We talk about, you know, what are the symptoms, how to check your guides every day. And those are honestly some of the best measures, better in many cases than a one moment in time test that may or may not be helpful. So I completely agree that education, setting a good example, I think, is key. So, you know, being a part of, you're a huge part of our communities. And so being a beacon and understanding that in order for all of our businesses to thrive, we need healthy communities. And so by healthy communities, it's wearing masks, it's avoiding, you know, big groups, it's hand washing, and it's setting a good example. So I completely agree with what Tina was saying. I think it's spot on. The other thing, just to address what Steve is saying, you know, the priority groups, it is somewhat unfortunate, and it makes people feel less valued or more valued. But you have to remember that the lower priority groups are when you're asymptomatic. So whenever anyone becomes symptomatic, they immediately become a higher priority, and they become very critical in our testing, tracing, and confining this virus. So it's not to say that that those limitations exist for symptomatic individuals. So it's just a distinction. So the big issue is, routine testing of asymptomatic people is where our heartache is, and our conundrum is about keeping, consumer confidence and being able to tell clients like, yes, we're testing people, as opposed to, yes, we're educating our guides, we have these procedures in place, you have a much longer list. So the testing is more of a perception to your guests, as opposed to what you're doing on a day-to-day basis to prevent the spread in the community and when you're out on the river.
Thank you.
Yeah, thanks, Amy. I would just add to that I don't know how you communicate with your group of outfitters and guides, but somehow to convey to them for us that if this whole discussion, because there have been a number of participants on the call, but the message that I want to say is you're really important, but we're handicapped with with the availability of testing. And if we don't test you or some of your clients, it's not because we don't think that you're important. We just only have enough for the highest priority patients right now.
Yep. Yeah. And as a rule, there's pretty regular communication that goes out to the membership, and I'd be more than happy, especially if, both for credibility and for accuracy of language or message, I'd be more than happy to pass along anything you'd like us to share, like me to share with the industry.
Okay. I just think the more consistent the messages are, the less stress that's going to put the frontline people under. And there's certainly a lot of discrepancy in communication from the state. I pull up Tina's website right now, and it makes you think, reading it, that there's unlimited amounts of testing and we can test everybody. That's not the case. So.
Yep. Okay. Well, folks, I guess Jeannie, Amy, Steve, actually we just lost Amy. So Jeannie, Steve, any last statements you'd like to make before we bring this thing to a close?
I don't have anything else. Thanks.
Yeah, Steve, you're on mute, Steve.
I think the message is very clear. I think, it's, don't be running in there willy-nilly for tests unless, mitigation is the answer.
Yep.
So, yes.
Yep. Well, and, I really do appreciate that message, and I guess we'll sort of phase out with this, but outfitters and our industry is always, we're leaders by nature. People who are outfitters and guides are leaders by nature. We're going into what are defined as necessarily risky situations and taking people through them. We do inspire confidence. It's a fundamental part of being effective in our industry. So this is it's a great opportunity, and I think we have done this in the past, not least in this situation, to meet circumstances again and to demonstrate that leadership that we have historically on this issue as well. And to show the support that folks in our community, Jeannie, and the Jeannies of the world need. So I really appreciate Steve. Thank you, and for anybody watching, you should also thank Steve for all of his work and time and effort around this issue, not least testing, but everything else COVID, and helping to put this together. It's largely Steve's brainchild. And thanks, Jeannie, and to all the panelists we don't have on here anymore. But thank you, Jeannie, for participating and for sharing with us. And to the folks watching, either now or in the recording, thank you for joining, and please reach out with any questions. I think that'll bring it to an end.
Thank you.
Take care, folks.